I'm gonna focus on a specific protocol here, which is just the foot bath. And many of the doctors who are probably already on this webinar know this and have been administering it. So just to kind of give a brushstroke, those of you who don't know, this foot bath is one of the more successful ones. I've seen a lot of success on it with plantar fasciitis, neuropathy, diabetic neuropathy, even like, foot drop and other things of that nature where there's issues with the feet. We've even had a few basketball players in here I've personally treated where they've had sprains, and this was able to quickly get them back in recovery. So the idea behind it is basically as Matt mentioned, it's on a direct current wave. So it starts with the black lead and then it runs to the red. You can always reverse that, but that's how it's set up in the normal procedure. So in this case, we have the patient's feet in water and we have the red pads on the top. So essentially what's happening is that current is contracting muscles on the bottom of the feet, and it's running that blood flow up towards the pad. And you'll see I'm going to talk through that, the way that setup is, but those pads are crossed and there's a reason behind that. And we'll get into that, but that's the basic setup. Now, let's pause for a second because, again, I want to mention this is a direct current wave. So this is something that's going to be unique to what this technology is, as opposed to alternating current. Do not try your TENS unit to do something like this. The reason why we can put it in water is because the technology allows it to do so. All right. So on this
Jake, can I jump in for just a second?
Yeah, absolutely.
I just want to make sure as we go through this throughout the presentation. If you have any questions, on the bottom of your screen is a Q&A. Please feel free to type a question that you may have. And as long as it's not technical, if it's technical, I won't answer it. If it is technical, I'll definitely turn it over to the brains on the presentation. But on the bottom of your screen, please, if you have a question as we're going through this, just feel free to type it and we'll try to get to it. Sorry, Jake, didn't mean to interrupt.
No, that's fine. Thank you, Matt. I appreciate it. So getting into some of the setup, the clamshell is that circular, you can see that there, that one is a red, but that's just to distinguish on those clamshell pads. One side is smooth, the other side has a rough edge. That's the side the current goes on. So the basic setup is just taking that blue sponge, placing it on that rough edge, and then we get into the patient's setup. It goes underneath the bottom of the foot. A common question I get all the time from doctors and others that are administering this is, does it go on the heel or does it go on the arch, or does it go, on the ball of the foot? I base it depending on what they're going through. If they have a lot of heel pain, I'll probably try to get a little closer to the heel. What I've noticed though is going on the arch, it tends to sort of disperse well enough where regardless of where you put that pad, they're still going to see a lot of the results. So just for purposes of being able to secure that pad well in the foot, I usually put it on the arch. And then of course, as you can see, I have a Velcro pad that we just kind of wrap around the patient's feet. And then we place that opposite pad there on the quad. So as you can see there, it's on the right foot and then the left quad. You would do the same thing on the opposite side. So you essentially just have those pads crossed. Now, the reason for that is you want a longer pathway, so to speak. So as those muscles are contracting, blood flow is getting into that area, you're also pulling that wave and you're getting inflammation out. So it just draws a longer pathway to get to that opposite pad. Look at it this way, there's two separate pads and they're kind of talking to each other. And as a result of that, when you have a longer pathway, it just pulls out inflammation a lot better. So that's one of the reasons we cross them. And then of course, this is that basic setup. Very simple protocol here, but has been super successful. And the patient sits there. Some of the things you're going to see if you're new to the technology and you don't do a lot of foot baths yet, just to warn you, when you turn up the power, the toes are going to curl a little bit. Sometimes you're going to get some heel raising. Nothing to be alarmed about. That's just the body reacting. It's not used to that force. We contract muscles at 500 times per second using this RX100. Your body contracts it at 2. So it's a major difference. But the beauty of it is, like Matt said, is your brain does eventually recognize it as a wave being harmonious with the body because it's on a specific direct current RC wave. So eventually, all you have to do is have your patient just breathe through it, just a deep breath in through their nose. On the slow exhale, a lot of times those curled toes, you can release that, the heels will drop, and then they'll be able to keep their feet nice and flat. So throughout the 20-minute session, I always recommend, as the current starts to subside a little bit, you just keep pressing that and turning that output power up as high as possible. It just represents force. So as the patient sits there, the more force that they're able to absorb, the better it's going to be for them, the faster the results they're going to get. And that way, the quicker they recover, they go out into the world and they can handle, whatever sport they're going through or just daily life. And we've had a lot of success with patients all the way down the board from, I've seen as low as 6 years old in the foot bath, as old as 90 plus, both getting results. So that gives you an idea. Again, if you have any questions, just leave it in there. Matt, I think I see a few here.
Yeah, Jake, I'll let you know. I mean, I think somebody wanted a little bit more explanation on the pads being crossed.
Okay, yeah. So let me go back to that. To reiterate, think about a pathway. If you just went from, let's say, the right foot up to the same quad, you have a shorter distance. So as the muscles are contracting, you're pulling out inflammation, so to speak, based on how that wave is going upward. But if you take that pad and you move it to the opposite leg, now it has to go up through the entire body. Your brain recognizes it also. Like Matt said, it's neurological. So you're registering it here, but it's going to that opposite leg. So there's a longer pathway to draw that inflammation out, as opposed to just going from here to here. Now you're going over here. So there's a much wider range where they have to pull out that inflammation. I hope that was able to bring out some of it.
Perfect. Yeah. Can the ARPneuro help a pronated foot?
Yeah. So that's with the foot bath, that's a kind of a loaded question, but in short, I would say yes. The reason for that, there's muscular breakdowns. Pronation or even supination, when you get into something like that, there's some sort of muscle breakdown that either is dormant, it's not firing, and this has the capability to fire those muscles correctly. I'm not suggesting that it's going to completely eliminate any pronation or supination, but it's going to help improve that. The idea around the technology is, think of your brain as almost a computer system. And if you've developed some sort of compensatory pattern throughout your life, your brain starts to kind of clam up because it wants to go into that fight or flight mode, or basically going into help me here, Dr. Arkfeld, I'm drawing a blank. Fight or flight mode.
Survival.
Yeah, there we go. So it pulls you out of that fight or flight mode. And the idea by that is you're kind of unwinding all those compensatory patterns, and you're removing all those kinks. And then you rewind all that. As you rewind all that, your brain is starting to neurologically reset, so to speak. So you're now developing the way the body should have moved before, thus removing pronation or supination. There's good and bad results. I mean, we've had great results in it, and sometimes it just depends on how long those compensatory patterns have gone on throughout your life.
Awesome. Yeah. One more question then.
Sure.
Would this help when a diabetic has an open sore on their heel?
Yeah, none of that will matter. Sometimes I would wrap it maybe away from that sore. There have been cases where I've even kind of getting a little bit more advanced where we don't wrap it. We just kind of place the pads in water, but not affected. In fact, as long as they're not, it's not an open wound where they're actually bleeding, it's not a problem. It probably will help that in many cases, just because you're getting more contraction and blood flow. Any other questions, Matt?
I think that's it.
Wonderful. Let me go to the next one, because this is going to segue right into our guest speaker, who I'm excited to.
Oh, Sorry, I do have one more question.
Sure.
Somebody that has actually used the foot bath. Should the patient try, like when you're revving it up, should they try to straighten their toes, or do they kind of naturally want to relax them?
So through the breathing, your body will naturally be able to submit, for lack of better terms, to where the current is taking them. And the reason for that is just that overload of high contractions and just that intensity of the current. When they breathe through it on the exhale, their body will actually go back. To force it, it's probably going to be harder to do, to be honest, because that wave is so strong. But when you breathe through it, your body will naturally go back to that state.
Very good. Thank you.
Absolutely. And of course, if you have any additional questions on the foot bath per se or anything with feet, again, info@arpneuro.com. We'd be happy to get back with you on that if you felt like you got overlooked here. The next one I want to go through is the concussion protocol. Now, the protocol itself is a pretty basic setup, but this is going to certainly segue into our guest speaker that I cannot wait for him to talk about what he has done with it. But essentially, we're going to start with the red leads. We take both red leads. So the RX comes with 2 cords. Within those 2 cords, there's 2 leads. So there's 4 actual pads, 2 black and 2 red. The 2 red leads are going on underneath the bottom of the feet. Just simply like this. We have the patient kind of laying supine, and both pads here on the red lead. So the current actually is ending here. If you remember, I said it starts with the black and it ends with the red. So the black will be running current towards the feet, and there's a reason behind that. But let me go to the next setup. So we take one of the black leads, whichever cord, it does not matter, and we place it on this, basically just below the hairline on the neck. I always recommend something where you can keep pressure on the neck, and we just have that patient lay back and rest just like that. So that is the setup here. Now, if you look over here in this first picture, you'll see I laid across the other black lead. I did that on purpose because that 4th lead, so to speak, doesn't have to be on the patient. We just ground it on that plastic. There was a case where I had a very large football player. He had a very large neck and he barely felt it. So we placed both pads on his neck. That was one exception. I'm sure some doctors can probably speak more to it. I seldom use that 4th lead, but it's not going to change the way this particular protocol works. And that's the basic setup. We set it for 20 minutes. With this particular layout now, you want to turn that output power up to the patient's tolerance. And the idea behind this is, in a concussion, there's some sort of pathway that's blocked. And what this current will be able to pull out is, as you're feeling contractions on the back of the neck, it starts to run down to the feet. Some cases, you're going to get one foot that's going to be a little bit more intense than the other, or they may not feel it at all. I've seen cases where both feet took a long time to feel any type of current. The way I kind of run that session is I want to keep turning that output power so long as they can tolerate it, and I don't see any weird compensations in their feet or their neck, and until both feet feel the current evenly, thus kind of resetting and getting them out of that concussed state. And once they do that, then we can kind of get them into a movement. Sometimes that takes longer, though. And Dr. Arkfeld is going to be able to speak more to this because he's become the expert in how these treatments are done. But that is the basic premise behind it. And, it kind of gives you an idea of, I don't know of any other technology out there, and someone can correct me, that is able to treat a concussion like this, get them out of a concussed state, and then get them back to, whether it's on the field, on the court, on the ice, whatever your sport may be, or if you're just a person who, not in sports, but you've suffered a concussion, you want to get back to work and get back to your regular life. This will balance you sometimes in just one session. And it's pretty amazing. I've seen a lot of results with this. But I want to show you this video very quickly. You might recognize him. That's Dr. Arkfeld, one of his patients, kind of going through. This is after they got out of that concussed state, but now using, as you can see, he has the smaller PRS unit as they're going through movements. And now, again, to segue to kind of where that is coming from, I want to introduce you to our special guest. So he has been in practice for 35 years, and he runs his chiropractic clinic in Gaylord, Michigan. He's a graduate of Northwestern College of Chiropractic. He sees a variety of patients, including student athletes, and he specializes in concussion management. Now, he also is active as a business consultant to chiropractic clinics and has published several books that serve as a guide for chiropractors who are looking to better understand coding and documentation, avoid lost revenue, and avoid audits. He hosts a podcast that's called The Neuro Way to Practice, and this is where he discusses many of these topics. He has been using ARPneuro in his clinic for several years now, and we're actually very honored to have him aboard today to share his firsthand experience using this technology and his concussion experience. So everyone, please give a warm welcome to my good friend, Dr. Arkfeld. Good to have you.
Thank you, Jake. Thank you very much. I want to thank ARPneuro for having me on. This is really an honor to be the first one in this series. And for those of you that have the RX currently or ARPneuro in your offices, it should have made a profound effect on your patients. The clinical outcomes should be through the roof. If you're not making at least $5,000 a month off this, something's wrong. Okay. And so that's the reason I'm so excited about this, because I have kicked the tires on this. I use the PRS, and we do a lot of what I call fun things with this. So I brought the technology on about 3 years ago, right at the height of the pandemic. And I was seeing about 50 sports-related concussions a year. I have a really unique practice in that I see chronic pain patients in the morning, and then I'm the team chiropractor for our local high school. We don't have an athletic trainer. I pretty much fulfill that role. So it's all sports medicine in the afternoon. 3 o'clock, the kids are coming in. So what initially drew me to ARPneuro was the concussion protocol. And then we got it in, and then the governor did, closed us down, schools were closed, and all of a sudden I wasn't seeing any sports injuries. So you know what happened? We went into COVID hours, and I was seeing patients with pain that couldn't get any place else, and we were using ARPneuro. ARPneuro kept us going. I did not qualify for any incentives because we didn't lose anything. And I was practicing 3 days a week, 3 half days a week. And it was the closest to a waiting list practice that I've ever had. And that when patients got done with one condition, we had somebody just step right on in and start doing with the ARP neurotherapy, and we just get going. And it didn't matter if they were Blue Cross, cash, or Medicare, they paid for this service because they found a value in it. So when school resumed and sports resumed, and we started seeing the concussions again. So the way that we start off our concussion therapy is, first of all, with everything with this technology, you've got to have a good examination. You have to take a good history, you have to have a good examination, and you have to be able to do a good neurological exam. You need to do cerebellar examinations. And the reason why is that our bodies are made up of receptors. So we have mechanoreceptors, Ruffinians, Pacinian corpuscles, kind of remember those guys. We have joint receptors, we have muscle spindles, we have Golgi tendon organs, all these receptors. And so the reason this therapy is so effective is that it helps fire up the brain. We get this information, we get afferent nervous system supply going up to the somatosensory cortex or the parietal cortex. And it bombards the nervous system, our central nervous system, with the information on patients that were what I call neurologically starved. So the patient comes in, they have a concussion. We do a really good history. We do a good exam. I do cerebellar testing, finger to nose, balance testing, and you're going to find abnormalities. And in the side that they drift to or fall to, that is the non-functioning side of the cerebellum. And so we want to stimulate that. The dizziness, the vertigo, that can either be due to vestibular issues, but more times than not, it's due to suboccipital muscle issues. And it's very widely overlooked. The suboccipital muscle, they have like per gram, like 240 muscle spindles, whereas the upper trapezius have like 5. So it's really another sensory organ. So what we began doing immediately with our concussion kids after I did that examination is that I would take them to the next level and I'd put them in the concussion protocol. The concussion protocol is diagnostic and it's therapeutic. So as Jake said, we will get patients that can't feel in, their legs, their feet, or they'll feel one more than the other. And we have to get that stabilized. We have to get them so they are feeling both their feet before I can move on and do anything else with our concussion treatment. Because with the concussion, it's an ATP energy issue, and the brain needs stimulation, it needs oxygen, and it needs nutrients. And so with the RX, I can take and bombard the central nervous system, the brain, with afferent stimulation. And that is absolutely huge. And that's the reason it's been really frustrating, is that we would get kids that are now in post-concussion syndrome, which is anything over really a month post-trauma, because they've been told, oh, just go rest, it'll take time, just keep resting, stay in a dark area, and you'll be fine. Well, that's absolutely the worst thing you want to do. You want to stimulate that central nervous system. So we start them off with the concussion protocol. And as soon as they pass, then we move them in to doing more neuromuscular re-education exercises. And that is 97112. I can't escape the coding because I love clinical and I love the coding. And so the neuromuscular re-education is you're going to restore proprioception or coordination and balance during sitting and standing activities. Well,
Hey, Dr. Arkfeld, can I pause for a second?
Sure.
When you said when the patients pass, they move on to the movement, can you explain what that is to you? What would you consider a pass?
Yeah, they can feel it in their legs equally and very quickly once we start that session. That can be, typically that is, I have not seen it yet to where it's before the third or fourth session. And so when I treat concussions, I treat them very aggressively. They're in my office daily. And so we're running this on them every single day. And so they go through the concussion protocol. As soon as they can feel it in both feet equally, then they're ready to move to the next phase.
Got it. So they're literally doing several weeks at a time in some cases.
Yes. Yeah. So what I'm trying to do is the initial stages, I'm trying to get the acute symptoms such as fatigue, headaches, visual disturbance. I'm trying to get those to decrease as soon as possible. We're trying to move the patient back into a return to learn situation. And I'm talking student athletes here, okay? So my initial protocol is they will be off school for 3 days. I need to give them a little rest. I need them to be coming into the clinic during that time, but I need them to just take a little rest from the lights, the sound, the noise. And then we start them on a return to learn protocol. The return to learn protocol is they go back to school the first day for a half day. That's it, just a half day. No matter if they think they're doing great, it's only a half day. They go back the next day for a half day, and then they go back the third day for a full day. Now, at any time, let's say they go back on a Monday, a half day, and they can't make it. They have a headache, they have light sensitivity, then they go home and we give them another day of rest and we try it up again on Wednesday. So then they're going back on a half a day, and then if they pass, they go to a full day. Once they make it to a full day, which we typically see the full day activities, they have already passed the concussion protocol. So they're feeling it in both their feet. Now we're ready to start in on neuromuscular re-education with them. And that's where we can put the pads on the base of the cervical spine. We can put the pads on the quads. We can place the pads anywhere. And we can have them start doing very simple exercises. We may have them just do squats just to get them moving and to get stimulation going up to the brain. The one thing that I love about the concussion protocol is that even though it's somewhat diagnostic, it's also therapeutic, and it's therapeutic not just to get the feet, the sensation restored at the feet, but also at the suboccipitals, because like you said, the black lead is up there and that's hitting those suboccipital muscles, and they need it. Because you see, you cannot have a concussion without having a whiplash. You cannot have a concussion without having a circular spine involvement. And so we are starting the therapy on the cervical spine at the same time we're doing the concussion protocol, which is absolutely huge.
Can you explain, because I know you're dealing with mostly student athletes. For the student athlete, what's a typical full on treatments in general? How many would you usually see typically before you pull them out of that concussed state and they're ready to go back to playing their sport again?
Okay, well, and I got to go into a little bit of the pathophysiology of a concussion then, so that you can.
Sure.
So basically, there's two phases of a concussion. When they get hit, it creates an electrical storm. You have millions of your brain cells that fire, and they shouldn't have fired. It was a false firing, but there was a trauma there, and they fire. Now, that results initially where you'll see a kid holding his head, start wobbling. You'd notice something's not right. And many times they'll come off the side of the field and you get them seated and they could be emotional and they're going through all this. And then a little bit later they go, I'm feeling fine, I can go back in. No, they can't, because that initial is called the electrical storm. And that's where all these brain cells fire and it creates a energy deficit. So you have ATP levels that just plummet. And if from basic biology, we know that the mitochondria is the powerhouse of the cell, manufactures ATP. Well, that just gets gummed up. There's a whole neurometabolic cascade that occurs, and it just lowers everything. So now they're in a deficit. The second phase of a concussion is now coming. It's called spreading depression. And it's because of these low ATP energy levels that you can't return them to play right away. It's very serious if they take a second hit. And that's the reason we know that it's going to take about 10 to 14 days before those levels return. And my coaches are great. I don't have any arguments with them. They just know that when a kid has a concussion, he's out for 2 weeks, mandatory. And so we treat them daily. We start them off with the concussion protocol. I'm doing very, very gentle chiropractic adjustments to the cervical spine. We're doing some soft tissue work up there. And then at about day 4 or 5, then we're going to start integrating more rehab exercises for them, because I want all these special receptors, I want them firing up into that brain, and I want that brain to get used to those demands. And at that time, the ATP levels are starting to come up. So at 1 week post-trauma, we put them on what we call the Buffalo treadmill test. And that's where we warm them up, and then we raise the incline up 1 level each minute, and we keep the miles per hour at 3.3 miles per hour. And we monitor them. We monitor their pulse rate and how they're feeling. If they get to like, let's say, incline level 5, and they start having a headache that is like a 5 or 6 where they started as a 3, we shut them down. That's sub-threshold clinical manifestations. And then we know that that's where we can push them up to that level. So we will take and use the RX through this whole time period. I'm just switching because really during the concussion protocol aspect, it's really almost like a passive therapy, I would say, because they're just laying there and letting the direct current work its way. But then we move them into active rehab, and we will start and we'll put the cervical spine, we work that first. So we will put the black pad and then a red pad on an upper trap, and we take them through cervical range of motion. And we'll do 4 sets of 5, then reverse it and do 4 sets of 5. And what I'm doing, 4 sets of 5, cervical flexion, extension, right, left lateral flexion, and right, left rotation.
So
And
you're
so we're
essentially booking
increasing
the neck protocol.
where it's the neck protocol. Absolutely. So after we get done with that, and this is one of the areas that I think that is largely forgotten. And this is, we have to remember that there is an emotional side to this. These kids are anxious, they're depressed, they want to know, are they going to get their life back? And so we do an autonomic nervous system treatment, and we use the relaxation protocol of the RX in conjunction with Normatec compression therapy, and then our brain tap entrainment therapy. So Jake, do you want to talk to them about the relaxation protocol?
Yeah, absolutely. So one of the things that we usually recommend is we use all 4 pads, and we kind of turn it. I like to turn it around the other way. So I run the black pads on the bottom of the feet, and then I will cross those pads to the opposite shoulder. So each one infraspinatus or posterior delt, whichever you like, try to just drawing that blood flow up towards the heart, light contractions. And they're doing the same thing. They're staying, they're laying face up, supine position, and just a light sensation. So yeah, that's essentially how I run it.
And that's what we do. And we combine it with the other therapies. Whenever we combine the RX with anything else, like you saw with Logan, we combine that with the Bosu ball and then Otis. I call that layering of the therapy. And so it's just another neurological input going into the somatosensory cortex. So what we're doing with this is we're taking that autonomic nervous system and getting them out, or fight or flight, lowering the sympathetic dominance, engaging the parasympathetic nervous system, and they're just happy. I mean, that's the best way that I can say. They just come out, they take a nap, and if I can get every one of the patients, when we do our relaxation protocol, if I have to go in and wake them up, that was a success that day. Because then it just turns their brain off for that time, and they can just relax. So that's how we are using it. And then when it's time to go into like strengthening exercises, upper body, lower body, because we do transition them into that, the RX is used again, and we put the pad placement on, and they're either doing curls or doing bench press or whatever the case is. And so we're taxing their system and putting some loads on there to see if they can handle it. And once they can handle it, and then we do a return to play. And that return to play sequence is going to be based on their sport that they're in. So
quick question for you, Dr. Arkfeld. And this kind of came in, and I sort of have this question as well for you, because I know you see a lot of athletes that come in, concussions, they have headaches or perhaps migraines. Have you seen any patients come in with migraines or maybe tension headaches, and have you put them on this particular protocol? And have you seen any results with that?
Like daily.
I figured. I know you have a train of this type of patient load. So
the migraine headache sufferers, and let's take the sports related injuries out of this. Let's just say we've got Mary migraine that's coming in. I felt like I really didn't have a tool to effectively treat them in the past. So we start them off with, we will do the cervical spine protocol to begin with. And we don't keep cranking the intensity level to where, they're in spasm and then they're waiting for it to release. I think we'll probably get up to as high maybe as 7 on that. And then we take them through, because I want that neck. I want the cervical spine to be moving. And then I'll do a real easy adjustment on them. And that could be Cox flexion distraction technique, could be a drop table, could be instrument assisted, whatever you have. I typically don't do probably a diversified adjustment right away. I do use a little pulse oximeter, and I'll be checking their pulse. And if their pulse is up there in the 80s, I'll shy away from a diversified, do more of a low force technique. But then we put them into the relaxation mode and put that on them. and do the Normatec and the brain tap as well. And it's amazing. They will come out and say that we broke that migraine cycle. And then it's a great lead way, because I'll say, well, you're in the office for like 40 minutes, maybe. How would you like to be getting the same therapy at home, and you can do it at any time? And that's when I introduced the PRS, and we do a home rental ourselves to them, and they love it. They absolutely love it.
In addition to the concussion protocol, and it perhaps is one of them, could you just give an example of just a patient success story that stands out to you? I mean, I know personally there have been several, but just one that stands out that you wish to share.
Oh yeah, absolutely. And actually she was in the video. That was Logan. And in the seminars that I teach on concussion, I always tell Logan's story. So Logan was a sophomore, and that's when I met her. She was playing varsity basketball, and just one of these scrappy defensive players that if you're the opposing team, she would just get on your nerves. But she did all the things that you would want as a coach. And I just would laugh at her and call her Scrappy Doo, because she just, for a sophomore, it was unheard of to be up on varsity, and she was just right there. So now we go into her soccer season, her sophomore year, and she sustains a concussion. And this was in May, and she was able to kind of grind through the rest of the year, but she's still having headaches. She's having light sensitivity, low energy. And she went to see a neurologist, and he told her, you just need to spend the rest of the summer in dark, quiet area, at least 18 hours a day. And that was so problematic on many levels. First of all, in Gaylord, Michigan, we have like a week of summer. So she took that, he took that away from this kid. And so she did that for the entire summer. She was just in a room away from the family and socialization. She didn't have friends over. School starts in September, and she is not doing well. She can't finish a day out. It's third day of school, and she can't finish the day out. She's got to call her mom to come get her. Her mother had been shopping at Meijer and come across another mother of a patient who had a concussion that I had treated successfully. And they said, you ought to go see Ted Arkfeld. He treated Brody with success. And so Logan came in. Now, granted, she's a post-concussion syndrome, totally different than concussion. And she came in, and I didn't know this girl. I mean, she was anxious, depressed. She had the 1,000-yard stare. It was heartbreaking to look at her. Absolutely scared to death if she was ever going to be able to play sports, let alone just finish school out. And this was a straight A student. So I did the exam, did everything. And I said, Logan, we got to get you moving. And so we did the concussion protocol on her, and she failed miserably. She couldn't even feel her feet. And it took us a week to get her to the point where she could feel her feet. Then we started doing dynamic stretching activities with her. And then we progressed her up to using the RX and going through different resistance exercises. And we are doing a lot of cervical spine protocol with her as well. And then relaxation. And so she came out after 2 weeks. She was headaches reduced by 50%. She was able to go to school and make it through school. The light sensitivity had gone away. After 4 weeks of care, she was cleared. She was good to go. She was able to start basketball practice that year. And then she had a second concussion in January. And I told her, we'll just start it all over again. You're going to be fine. We'll get you through it. Everything will be great. And so we took her through all the protocol again. And it was really interesting because nobody thought she would play. Everybody thought she'll never play soccer again. And I got her going in early March, just going outside and running. And yeah, she had a headache. And I said, don't worry about it. Only worry if it spikes by 2 levels. She went away to spring break and then came back. Season started, and it was about the 5th game of the year. And We did all of the return to play considerations. She passed her Buffalo treadmill test. And I called the coach. I said, she is ready to go. He goes, well, she's still having headaches. It's okay. They're not spiking. She's having headaches because she's still a little out of shape, but I'm not concerned about it. She doesn't have anything else. She's ready to go. Now, here in Michigan, before a kid can be returned to play, I can't clear them as a chiropractor. They have to be cleared by a medical doctor. And her family doctor is along the sidelines with me with our football games on Friday. So he called me up and he goes, is Logan ready? I said, yeah, she's good to go. He did a real brief neurological exam, signed off, said, good to go. So I'll never forget that day. We were playing Harbor Springs. A lot of those girls were on Logan's travel soccer team in years past. We had a pretty good crowd because word had gotten out that Logan was going to be able to play. And so we had a really good crowd, student body, the whole works. And about halfway through the first half, coach said, Logan, get loose, you're going in. And she stood up and stretched out and went and was waiting for a break in the play. And as soon as she ran onto the field, she got a standing ovation from all the parents, the student section. Most of the Harbor Springs kids stood up and were clapping. Girls out on the field were clapping. And I turned and looked at her mother, who was up in the stands, and she was crying. And she was pointing down at me. And the next day she came into the clinic, the mother, and broke down and started crying and said, thank you for giving my kid back to me.
Wow.
That's why we do what we do as chiropractors. And that's why we have got to start seeing more concussion patients, because we are uniquely situated to do it. And we can make such a difference in their lives. And this is, I'm just talking about a concussion. I have seen stories and could tell you stories over and over again on what patients are calling a miracle with using the RX. And that's a word I hear a lot, that this is a miracle. And so we just have to keep growing this network and getting the word out, because there's a lot of Logans in people's areas that we've got to reach and start helping them.
Let me unravel that a little bit with Logan's story, because that one's touching. I've heard it before and it still gives me the chills. Where does her story go if she's not being treated by you and using the ARPneuro therapy and the post-concussion that you did with her?
You know, it's really interesting, Jake. We've asked, I liked Logan so well that I hired her. She worked in the clinic for 3 years before she went on to college. And that topic has been brought up a couple of times. And she told me she was leaning towards thinking about suicide. It was getting that bad. And I don't know where she would be. She wouldn't be down at Central Michigan University in her junior year as an interior design major. I can tell you that. And that's the reason I really started going down into this neurological pathway and learning more. I didn't take Carrick Institute classes. I started taking other neurological things that I thought would be easy to implement into the practice. And I built what I call the Neuro Way to Practice. It's a philosophy. It's how we treat patients. I built it totally around the ARPneuro. And I realized that there's a lot of Logans out there that we've got to get the word out to the chiropractors. And it has been very difficult, to be honest with you, because a lot of chiropractors, I think, automatically assume, well, concussion, you bring up brain and maybe neurology, and they get a little freaked out about it. But concussions are very, very easy to treat, and I can teach them how to treat it, and then how to use all the various protocols that we've come up with the RX and then with the PRS to be wildly successful. You don't need to be involved with the athletic teams like I am. As a matter of fact, the concussion treatments really started even though I've been with the teams for 21 years, it really, I only started treating concussions about 5 years ago. And it came as a parent looking for answers to their kid who had a concussion and they weren't happy with what they were hearing. And so you don't have to be on the sidelines. All you need is a parent and a kid that had a concussion and they're not getting anywhere and they're looking for answers.
One last question. I appreciate you being so open about what you've shared, but other doctors who currently don't have this technology, they're hearing your stories, they're hearing, what you've done with concussion, and they're considering this technology. What advice would you give to them as to whether or not they should bring it in their practice?
Well, I'll tell you that we have a broken business model in chiropractic. It's been a business model based on passive therapy, and that has been ever since I graduated. So you do hot packs, muscle stem, ultrasound, massage therapy, laser, spinal decompression. I will tell you that we have another doctor in town that does laser and spinal decompression. And I get a lot of patients that come because they're not getting results with that. And we get results with the RX. We get results with ARPneuro. I'm just going to say it, we kick his butt when it comes to that. And it's competition. And if you don't think it's competition, we got competition with other chiropractors and with PTs and pain management.
Sure.
This is the most amazing technology I've ever seen. We are transforming lives. And the return on the investment is unbelievable. So I would tell the doctors that do not have this technology that if you have a laser, sell it and buy ARPneuro. Get into ARPneuro. The chronic pain, the acute pain, concussion is just one part of this. We see so many things, and it's kind of funny because yesterday I had a patient that came in I hadn't seen for years. Came in, it was a simple rib out, and I did the adjustment, walking her back up front. She goes, "Hey, do you know of anybody that treats plantar fasciitis?" Yeah, I do. She got a foot bath yesterday, and she's scheduled out for the next, I'll see her again tomorrow and then a couple times next week, but she felt great. We did the protocol. So it opens up your practice. Now, getting back to the broken business model, passive therapy only. Our goal has to be movement. We have got to get these patients moving from a neurological standpoint. We've got to do a good exam with movement. We got to set a baseline. Movement can only occur with active rehabilitation. You can only do active rehabilitation if you have the right equipment, and you don't need thousands of dollars of equipment. You need the RX and you need PRS. I won't bore you with the details, but we had a flood in our beautiful clinic that we were in a year ago. I had to leave there, and it was almost prophetic, because I used to tell doctors, you only need 1,000 square feet to do this, and you just need this unit here. Well, guys, I'm in 1,000 square feet, and I'm using the RX and I'm using PRS, and we're getting great results. And the income level off your active rehab, if you're not getting at least 5,000 or more additional revenue based on the RX, you need to call me, because you're not coding right, you're not doing something right. And so from a revenue center, it's unbelievable.
Wow, this is first of all, great presentation. I don't know how we're going to top this as our first. This is incredible. What a great story. Very excited to hear, kind of the success. And boy, have I learned a lot, on the concussions. I have a million more questions. So, and we want to kind of wrap this up, because of the time commitment, but we are absolutely going to have you back, because I've got a list of about 10 questions that I want to ask that I can't, just because I want to be respectful of everyone's time. But
sure.
Fantastic. Jay,
Thank
great
you.
job. Dr. Arkfeld, unbelievable. What a great start, first presentation to educate our listeners today. So thank you so much.
Thank you
Jake,
for having me.
Yeah, Jake, do you want to
Appreciate
wrap it up, or I think
Yeah,
that's
wonderful stuff. Thank you for everybody on your time, just taking the time to be here. Dr. Arkfeld, it's been a real pleasure. If you want to check him out on his podcast, it's the Neuro Way to Practice. And is there another link we can reach you at, Dr. Arkfeld?
Yeah, you can email me at ted@neurowaytopractice.com.
ted@neurowaytopractice.com for any questions you have for him. Also, we're ARPneuro.com. If you have any questions, you can also send it to info@ARPneuro.com. Once again, great stuff. Thank you for your time. And we'll be back next week for the PRS side. So if you guys are enjoying these webinars, we're going to have more of this, and we'll see you next Wednesday. Check it out on the website. You'll be able to sign up there. But thanks again, Doc, for our Arkfeld, for your time, and everybody else for being here.
thanks, everybody.
Bye, guys.
Great. Bye-bye.
Bye-bye.